Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I'm back today with an interesting head and neck radiology case of the day. This is a bit of a challenge case. So I want to start off by saying that all of the educational content found within this educational learning tool has been completely de-identified in order to protect patient privacy. Okay, so here's the history. This was a patient who showed up with a history of IV drug abuse, and they showed up with, among other things, new miosis and ptosis, but no anhidrosis. So I have just two images for you to look at today. The image on the left is an axial T1 weighted image, post-contrast, fast-saturated image, and the image on the right is an axial diffusion weighted image. It's the diffusion trace. So again, post-contrast, axial T1 with fat saturation on the left, axial diffusion trace on the right. So, what are the findings? What's your diagnosis? And why the incomplete Horner syndrome in this case? They have 2 out of the 3 classic features of Horner syndrome. Why do they not have a full Horner? All right, let's take a look at the imaging. So first up, we have our T1 weighted image, post-contrast fat saturated sequence. And what we can see is edema and enhancement predominantly involving the right face and periorbita. So you can see here we've got the muscles of mastication that are thickened and enhancing. We've got myositis. We've got all this, sort of subcutaneous edema and enhancement and potentially phlegmon. And it's also retroorbital. If you take a look, we can see this sort of strandy enhancement within the retroorbital soft tissues as well, within the intraconal space, is where the arrow is pointing at. It's actually a bilateral finding, but it's worse on the right than the left. And if you look very carefully, you'll see that we have multiple filling defects with associated perivascular enhancement. So if you look carefully, you can see that we have this widened cavernous sinus that has sort of this stringy filling defect within it, out laterally. We can see that we have this cortical vein, which centrally has a filling defect and has perivascular inflammation surrounding it. And if you look carefully, there's numerous scalp veins that also have filling defects and surrounding almost concentric enhancement. Now let's take a look at our diffusion weighted imaging. And again, this is our diffusion trace sequence. And corresponding with those areas of vascular filling defects, we see bright diffusion signal intensity. We can see it within the cavernous sinus, denoted by the yellow arrows here. We can also see it within that cortical vein. And we can see it within numerous scalp veins as well, really all throughout the right frontal and parietal scalp. And then if you look carefully, you'll also see that same bright diffusion signal within the superior ophthalmic vein as well. So, sort of a take-home point from this slide is that diffusion-weighted imaging is not just for stroke imaging. You can actually use it for lots of applications within the head and neck. I'm not suggesting that thrombus is always diffusion bright, but depending on the age of the blood products, depending on whether or not there's hemorrhage or not within it, you can oftentimes see diffusion signal abnormality that is associated with thrombus. Again, it's not perfect, but be on the lookout for it. It's something that you will sometimes catch on your diffusion sequence. And because the signal to noise is so high, because we've saturated out all the most of the soft tissues, particularly those that contain fat in the extracranial head and neck, oftentimes you have very high signal to noise where the pathology shows up very bright against that dark background. So what's your diagnosis here? And again, why does this patient have an incomplete Horner? Okay, so this patient had Horner syndrome, or a partial Horner, and it was due to septic cavernous sinus thrombosis. So classically, Horner syndrome presents with a triad of ptosis, miosis, and anhidrosis. And you get a Horner syndrome because you have disruption of the oculosympathetic pathway, or the OSP. And so that provides ipsilateral sympathetic innervation to the eye dilator muscles, hence why you get miosis if those get taken out. You get sympathetic innervation of your eyelid retractor muscles, so if those get knocked out, that's why you get the droop or the ptosis. And then also the facial sweat glands and the lacrimal glands are also supplied as part of this pathway, hence the anhidrosis, and kind of along with that the lack of tearing. So the bad news is this is a bit of a complex pathway, and that's what makes this a challenging case, at least a challenging case to wrap your head around and explain all the findings, but we can do it in this case. So this is a complex pathway that really dictates your search pattern. And I like these Horner cases because this is sort of the where the Venn diagram of brain, spine, and head and neck imaging all overlap, because this oculosympathetic pathway has components that are in the brain, components that are in the cervicothoracic cord, and then components that are in the head and neck regions and the soft tissues. So if you have a pathology along any of those segments of the OSP, that can result in a Horner syndrome or potentially a partial Horner syndrome. So your search pattern and your workup really are predicated on you knowing where this pathway is, but you also need to know, or at least it's helpful anyway, to know whether or not this is a pre or a post-ganglionic Horner syndrome. I'm not going to get into that with this case. That's something that clinically they can tease out using cocaine or amphetamine drops in the eyes, and they can try to figure out, are we dealing with something that's pre-ganglionic or post-ganglionic? We're not going to get into that, but it can be helpful to know whether or not the lesion, based upon clinical presentation in response to clinical tests, is at the pre-ganglionic level or a post-ganglionic level. That can sort of dictate, are we dealing with a brain problem down to the cervical spine, or are we dealing with something that is more head and neck and the surrounding soft tissues? Okay, so let's talk briefly about this complex oculosympathetic pathway. Starts with your first order neuron that originates in the hypothalamus, and that's going to descend in the reticular formation all the way down through the cervical cord to sort of the upper thoracic spinal cord, that cervicothoracic junction. And that will synapse with the second order neuron that's part of this pathway in the ciliospinal center. That ciliospinal center in the cord is really sort of from that C8 to T2 nerve level. So it's important to keep that in mind. We're dealing with something that, just think of it as involving sort of the distal cervical and upper thoracic cord. Now that second order neuron departs from the ciliospinal center, and it's going to travel with the C8 through T2 nerve roots down through the stellate and middle cervical ganglia, and that's going to synapse with the third order motor neuron at the superior cervical ganglion, which lives at the C2-C3 level. So it's important to keep in mind, again, if you have that clinical history, are we dealing with a pre-ganglionic Horner based upon their clinical testing, or a post-ganglionic Horner? That can really up your sensitivity and specificity as you're looking for causes along the course of the oculosympathetic pathway. So once we've had that second synapse, now we are entering into our third order neuron, which that synapse again is in the region of the superior cervical ganglion, and that's going to ascend in the carotid artery adventitia. Now it's important to keep in mind that your common carotid artery is going to bifurcate into your internal carotid artery and your external carotid artery, and that's where you potentially have a site in which you can add more granularity as to whether or not you have a full Horner or a partial Horner, like it is in this case. So if you have those sympathetic fibers that are traveling in the adventitia of the internal carotid artery, those will end up going through the cavernous sinus, it's where we have a lesion in this case. They hop on cranial nerve 6, or the abducens nerve, for a very short segment within the cavernous sinus before jumping over to the ophthalmic nerve, or cranial nerve V1. They ride along cranial nerve V1 and then hop off and transmit along the long ciliary nerve, entering the orbit, at which point they will innervate the retractor muscles of the eyelids, the dilator muscles of the pupils, the lacrimal glands, and then there's also some orbital vasomotor fibers as well. So as you can imagine, if you have a lesion that's somewhere along the course of the ICA all the way out to the end organ, which is the orbits, you may get 2/3 of your Horner symptomatology, but you may not get that facial anhidrosis. That comes into play if you have involvement that is more proximal, that also injures those sympathetic fibers that will eventually run along the course of the external carotid artery, then travel along the imax, or the internal maxillary artery, and eventually innervate those sweat glands of the face. So it's a complex pathway. Just remember, hypothalamus, reticular formation down through the cervical cord to the cervicothoracic junction, exits along those C8 through T2 nerve roots out to those cervical ganglia, and it makes its way from that point up along the carotid artery. Some of those sympathetic fibers will travel with the ICA, some will travel with the ECA, and those supply very different things. The ICA fibers, again, are going to course through the cavernous sinus. You have those sympathetic fibers that then jump onto cranial nerve 6 before cranial nerve V1, the long ciliary nerve out to its end organ innervation in the orbit. The other branches, the other sympathetics that go along the ECA, well, those will eventually make their way out to the sweat glands that supply the face. So a bit of a challenge, but something I think that if you look at a couple times, read through this pathway, it's pretty simple to wrap your head around, given it a few reads. There's a nice, very nice paper actually by Deborah Reed and Wendy Smoker, who are really kind of experts in the field of head and neck radiology, to say the least. But they have a very nice paper on Horner syndrome. It was found in Neuroimaging Clinics of North America from 2008, with some very nice diagrams. I would highly, highly recommend that this is something that all radiology residents, and especially all neuroradiology fellows, take a look at. Again, it really goes into great detail about these pathways, about the symptomatology, about the clinical workup, with some really nice examples of pathology. So I can't recommend this article enough. This is really one that I think is required reading for anybody that does neuroimaging. Okay, so let's wrap this up. Again, this was a case of Horner syndrome, and in fact it was a partial Horner syndrome, and this was due to septic cavernous sinus thrombosis in this case. So the key imaging features to keep in mind: we had a filling defect within the expanded cavernous sinus, and then we also saw lots of additional thrombus within cortical veins, within the superior ophthalmic vein, and within the scalp veins as well. I want to stress to you that thrombus may be diffusion bright. Certainly is not always the case. It's not a perfect pulse sequence, but it can be a very helpful pulse sequence from time to time for looking for thrombus. And we also saw a lot of perivascular edema, lots of facial and periorbital phlegmon, and that was all a result of this septic thrombophlebitis and facial cellulitis due to the patient's IV drug use. Okay, some pitfalls. It's really important if you're reading neuroimaging, you have to be familiar with the course of the oculosympathetic pathway. And this is not because it's just some obscure anatomy that we head and neck people like to challenge you with, but rather this dictates your search pattern in these patients who present with Horner syndrome. And so if you want to accurately localize a lesion, you really need to know where this OSP goes. Because treat it virtually like any cranial neuropathy. You need to image from sort of the origin nucleus, which in this case is the hypothalamus, all the way along the course of the nerve, which spans the cervical thoracic cord, as well as the soft tissues of the neck before going through the cavernous sinus and into the orbit. And it's really critical that you look at that whole course of this oculosympathetic pathway whenever you're trying to look for a cause for a patient who presents with Horner syndrome. And again, I want to stress to you, diffusion-weighted imaging, don't leave home without it. It's not just for stroke imaging. It can oftentimes provide very valuable information, whether that's by having increased conspicuity of extracranial head and neck lesions, or if you're looking for potential cellularity within tumors. I think it's an extraordinarily valuable pulse sequence, and really, I think it's something that you ought to be doing on all of your head and neck imaging protocols, regardless of what you're potentially imaging for, just because it can help you out in times that you would not even expect that it would be a helpful sequence. All right, that was kind of a long case of the day, but thanks for tuning in. As always, please join us on Twitter at NAKuntz, and I would invite you to check out the complete collection of IU Radiology Case of the Day material that can be found at radtf.iuhealth.org/COTD. Thanks so much.